There you go. Alright. I just start. She's not responding. I don't know if she had to log off or not.
Okay, guys, this is not a very in-depth lecture. This was originally created for the NFL for a national meeting, basically to bring people up to date when to use antibiotics, when not to use antibiotics, especially for the locker room at the NFL level, but you can matriculate it down to all levels in the locker room care. Now, this is coming straight out of residency. I hope this is simple review for you because hopefully you guys were taught well when to use antibiotics and not to. But globally, not everybody who practices sports medicine is up to date. I have no conflicts other than the fact that my boys play football or have played football. We're mainly going to focus on upper gastroenteritis, which is acute inflammation of the lining of the stomach and the intestines. Most of the time, it's viral. It can be bacterial. Common symptoms: diarrhea, vomiting, nausea. You often end up having the porcelain and looking like that. It's Austin every Friday at 3. Diarrhea. The true definition of diarrhea is liquid, loose stools. Worldwide, this is a big cause of death. We take it for granted in our first world country, and it's a nuisance to us, but across the world in third world countries, it is actually a killer of many people. 1 in 5, 20% also. In the US, it's, like I said, a nuisance. It's self-limiting. We usually treat the symptoms and people respond well. We have a much better diet, a much better health system, and hygiene on a daily, regular basis. The definition: loose, watery stools more than 3 in a 24-hour period. Within acute diarrhea, the definition is it has to be 14 days or fewer. Dysentery is what we often hear about when we hear about people dying from diarrhea, and that's invasive. That's when the microbe invades the lining, gets in to the cells, and you see some obvious blood and mucus in the bowel movement. The big questions here: when do we get labs? When do we test the stool? And when do we start empiric antibiotics? And that's really the focus of this talk. Let's talk about the causes of acute gastroenteritis. Norovirus is the most common. You know where it was originated? Norwalk, Ohio. That's how it got its name.
I mean, it's a great thing.
I was gonna say Norway.
Yeah, Norwalk, Ohio. There was an outbreak, and that's where they isolated it. The viruses are the most common, shorter duration. Rotavirus is something you guys are very familiar with, especially when you take care of peds. Adenovirus, which I always think of as the watery eyes from the nose virus, but it does cause a lot of gastroenteritis. But our viruses are the most common, but very shorter duration. The bacteria, E. coli, Shigella, Salmonella, the things that we usually think about from bad food, especially chicken, these are more severe. And they're very longer duration. But norovirus is the #1 still. That's what everyone gets on outbreaks of cruise ships. There's also the prozo. We can't forget about Giardia, Cryptosporatum, Intermedia. My brother-in-law's family all got Giardia from a lake 10, 12 years ago, and it really, really screwed him up for a long time. And one of the sons, he's still, we think that he probably, some of his GI issues are still related to a delayed diagnosis of Giardia from about 10, 12 years ago. These are very rare for acute diarrhea. The viruses are more common. So when you come across this with a patient, and I see this often in the training room, players will come in, you know, doc, I need something for my stomach, you know, I got the bubbles or whatever. And, you know, pooping everywhere. But you want to get a good history. You want to know the duration. When did this start? How long has it been going on? How frequent are the stools? We really want to inquire about the characteristic of the stools. You know, is it loose? Is it watery? You know, I always say, does it look like soft serve ice cream or does it look like brown water? You know, do you see blood in it? Do you see anything floating around that on the surface that, you know, looks like it's not supposed to be there? But you also want to ask about other symptoms of subjective fevers and chills. You know, one knows how to answer that right. So, you know, do you feel hot? You get sweaty when you're trying to sleep at night? Is this causing abdominal pain? And, you know, how do you urine? Is it starting to get dark yet? That's going to be rare in the training room. Most of our athletes hydrate better than the normal population and better than the third world. And then you want to ask about their food history. Okay, when did you get Uber Eats? And you know, talk about travel history. For me, during the off season, I have guys that travel all over the world. You know, I have you know, several players who are originally from Africa, and they go back to Africa, and parts of where they travel is third world. And you know, I've got one of the former linemen went to Russia for about 6 weeks a couple of years ago. Also, you want to ask about recent antibiotic use. Now, you know, if you're taking care of the team, you usually should be aware of that. And it's usually not going to affect our younger population, but it can with the older population. So I always, you know, don't get full set of vitals, but you know, pulse and blood pressure. Important to get for this to check their hydration status. I always check their temp. Do a really good abdominal exam. You want to make sure there's no rebound of guarding, anything like that. And look in their mouth and nose to make sure the mucous membranes are still pretty moist. Now, labs, we rarely ever get this, right? And you know, I remember being a resident and being an intern and having a patient my upper level every time she'd want to order O&P on anyone with diarrhea. And I'm like, why? Why are we doing this, right? Because it really wasn't wanted. It was just kind of a shotgun reaction when you admitted someone at that time, I guess. But when it is warranted, you know, this is when people are really sick, very hypovolemic, multiple stools over 6 in a 24-hour period, true fever, some bloody diarrhea, and really bad abdominal pain. And for anyone with symptoms lasting over 1 week. What do you get? Well, obvious stool culture, that's going to give us Shigella, Salmonella, Campylobacter. With bloody diarrhea, you're going to want to check fecal leukocytes, lactoferrin, the E. coli test, and the Shiga toxin. O&Ps, you know, very, very rare, but if they're having symptoms for more than 14 days, you want to get this, and you have to get 3 consecutive days of specimens. I mentioned, you know, I had a player who recently traveled to Russia, and you know, the worry is if they're drinking the water streams. Most people don't do that, but some can. We don't really worry about the hospitalization. for over 3 months. We don't really see that in our healthy population, but that can happen. What do we do for these people? Well, general measures, you really want to encourage fluid replacement. You want to improve their nutrition until they're able to keep things down. Sometimes we use medication, very rare. Initially, it's more for symptoms. And when do we start antibiotics? It's not routinely indicated to do right out of the chute. So fluid replacement, this is the most critical, and the most important is our oral replacement. You want to have our body salts and sugar solutions mixed with the water. With our mild symptoms, people who are not hypovolemic, people who have once membranes, have good blood pressure, you can get away with diluted fruit juice. That's what we always recommend to the pediatric patients. You can do the sweat replacement, sports drinks, numerous ones. Encourage them to eat salty foods, soups, saltines, beef jerky, anything like that. We know salt's very important for fluid retention. When people get hypovolemic and moderate illness, we got to kind of step up our game. You know, the World Health Organization has an amazing packet that's been around for decades of oral rehydration solution, and everywhere else in the world, they use this actual packet. So all the third world countries, if you go on any kind of mission trips, you're going to use this packet, and the contents haven't changed in decades. I think I still have at least one of those packets somewhere. And I think I still have my bag from my fellowship.
Don't take your bags from your fellowship.
And my fellowship, since there was only one fellow, they bought us and gave us a bag. I think it's in that bag somewhere in my basement, but I still have it. But the oral rehydration, you know, is something that works really, really well to help with anyone who is moderately hypovolemic. Then there's the commercial solutions that we're all very familiar with. These grow more and more all the time. Pedialyte now has a sports section that's marketed. You know, of course, they got our former wide receiver number 13, Mr. Beckham, to be their spokesmodel a few years ago. Natural light there at the bottom, not to be confused with natural light, from the same phonetic nature, but different spelling. So you want to avoid alcohol. Okay, Austin, got that? I've actually never seen natural. I've never seen natural light solution, but I normally don't walk down that aisle of the grocery store. I usually don't go to the grocery store. We do know things like Pedialyte and the direct or rehydration solutions that are made more for medical are a lot better than the simple Gatorade's power. It's because they have higher volumes of salt, potassium, magnesium. You know, now there's a lot of the market for this has really boomed in the last 5 to 8 years. I'm a big consumer of Element. I think that's probably one of the best. I'm fortunate I walk through a professional organization locker room multiple times a week and then see what they have set out. And I've tried several of them. And Element's the one that I think is probably the best out there. I have my Kidgey that I actually put it in my coffee every morning. I get the chocolate or chocolate caramel flavor, put it in my coffee. Lo and behold, my feet cramp that I get every now and then has gone away for the most part. The oral rehydration solution, as we talked earlier, greatly underused in the US, more worldwide is used. We like to give people IV fluids. You guys have seen it in the training room. You know, very, very overused, not needed. I always give the argument. I try to be scientific with the players and trainers when they ask about that. They think IVs are so simple. And not problematic, right? We've all seen or heard about really bad complications with IV fluids. But they expect that, that it's just something simple, just stick me with a needle, put fluid in, and we know there are complications with that. So, but I do my best to explain to the players, look, our body's not stupid. If you give a big bolus of fluid in a short amount of time, your kidneys are going to react and pee it out if you're functioning. And most of these guys aren't sick, they're getting it more for reasons that aren't truly medical, more superstitious. When people are severely hypovolemic, which occasionally happens in my world, someone who's had really multiple bouts of vomiting, diarrhea, and these are big guys, it's much easier and quicker to rehydrate them with IV fluids. But once they are able to get enough volume in with a euvolemic and not having any positional tension or anything like that, we can switch them over to oral rehydration solutions. Nutrition, very important. You want to start with a liquid diet, especially if they're having nausea and vomiting. We want to avoid things that are going to irritate the stomach. You can give them boiled starches, cereals with salts, crackers, bananas, the old brat diet. Definitely you want to avoid fatty foods, dairy products, which can irritate the stomach. We were all taught the brat diet, right? And there's actually some really good studies that are now 20, 25 years old that really show that may not be the best thing. When you're reintroducing food to people, it's really what they normally eat, what their stomach is used to seeing. So my recommendations that I've been giving people is, look, avoid greasy fatty foods, avoid spicy foods, avoid dairy, but otherwise introduce small volumes of what your body normally needs. So the cells are going to be familiar with what they see. We don't normally start people on antibiotics for acute water diarrhea. The exceptions, as we mentioned before, severe symptoms, more than 6 stools a day, completely depleted, volume depleted, fever, blood or mucus in the stool. And what do we use? Well, the number one recommendation is azithromycin, right? So a single gram dose or 500 daily for 3 days. You need to know your population, give them the best, right? So for me, with my population there in the NFL training room, I'm going to give them the simplest dose, just a single azithromycin. Fluoroquinolones, we know the concerns with athletes, right? The tendon. In 20 plus years, I've yet to actually see that in real life. I have had an older patient, between 60, 65, that did have bicep tissue from being on a fluoroquinolone. And I think the contraindications are more qualifying higher for our older patients than they are for younger patients, but still it's a warning that's out there. And you never want to be the cause of someone missing a game or losing a season. So I avoid fluoroquinolones as much as I possibly can. But if they're off season and for some reason you can't get azithromycin from your pharmacy because they're out of it, you can go with Cipro 750 for a day. And these pretty much just reduce your symptoms for 1 to 2 days, and the body helps get rid of everything. The symptomatic pharmacology, use with caution. I was taught, and I still practice this, that, I do not put people on loperamide as soon as they walk in having diarrhea. I've got a trainer who expects that. I think I probably have a couple partners that do that really quickly. I think the body's smart. And the body wants to get rid of that toxin. That's why you're having diarrhea. It's trying to evacuate. And if we tell the body, no, we're gonna stop this, then the body gets even madder. So I don't use that right away. After 24 hours or close to 24 hours of symptoms or multiple episodes of diarrhea, that's when I'll give it to them. If the standard dose is 4 grams right away, and then 2 after each loose stool, maximum is about 4 doses, 4 or 5 doses in a 24-hour period. You don't want to do this with bloody stool, because that's going to be material. You want to keep that in the body longer than it needs to be. You don't want to do this for more than a few days. Bismuth salicylate, which is one of my favorite medications in the world for the past 50 years. I don't know, Sue, I don't know how much you use that with your kids or you've used in training, but I recommend this all the time. For me as a kid, I fell in love with the taste. I remember being at a birthday party doing my truth or dare thing. I took the dare and they're like, "Oh, you have to do a big spoonful of Pepto." And I'm like, "Yes, yes." I love the taste, but yeah, I have reflux. I've been diagnosed with a high alarming, but I used to have a lot of reflux when I was a kid, and Pepto was the answer that works really, really good. Definitely when you give someone Pepto-Bismol, it's gonna, I prefer if anyone's having upper GI symptoms that they do the liquid, because it does coat the esophagus. A lot of them don't like the taste, they want to do the liquids. If you remember being out at the training, there's a candy jar full of the Pepto tablets, right? Besides them getting stuck in the teeth, I just don't think it's as effective as the liquid, but it's a good option now. You can get the liquid capsules that are, capsules full of the liquid, a lot more expensive, and do the trick. You have to warn them if they're going to do this for more than 2 weeks, right? Expect your stool to get dark and tarry. If you do multiple doses, it can coat your tongue, and your tongue can be black. And so if you're not used to that, familiar with that, that'll scare the heck out of you. And the alternative for the bloody stool is bismuth salicylate. So you should use that for any kind of symptom relief if they are having bloody stool. In head-to-head studies, loperamide does give faster relief than bismuth salicylate, but again, there are some contraindications of using one versus the other. Probiotics and zinc, really no good studies. There's nothing else out there from a naturopathic standpoint that has been shown to be really beneficial. Nothing that I would ever recommend. Activities, what are you going to do? Well, you really need to pull this guy from any kind of activities, and I even, if they're pretty symptomatic, pull them from meetings. Not everybody is good at hygiene as you hope they are. Touching things, shared objects in a room happens, and this can be a bad pandemic in your locker room. You don't want to. So, if they're really uncomfortable, often, I'll keep them back in the training room away from everybody meetings and see how they recoup for the morning and see if they can kind of be around for the rest of the day. Definitely don't want them practicing if they're having recurrent bouts of diarrhea and having any kind of fever. What is the follow-up and return to play plan? Well, in our country, this is a short-lived thing. Prognosis is excellent. Everyone usually returns to normal. Once their euvolemic and diarrhea is improving or resolving, they have to start returning back to activities, being afebrile for over 24 hours, being symptom-free from diarrhea, vomiting over 24 hours is what's recommended. In review, this is a high frequency issue that I see in the training room. You guys are going to see, if you're taking care of college or higher, your high school training rooms, most of these kids have mom and dad at home. the coach at home, right? And mom and dad are going to take care of this, take them to their regular medical doctor. Usually you're not going to see this as often in high school training room. But at the college level and professionally, you're going to see this quite a bit. As we talked about, the norovirus is the most common. Symptom duration is usually 12 to 60 hours. You usually don't do any lab testing. You usually don't start people on any kind of antibiotics. You want to start doing volume replacement. You want to treat their symptoms. This is self-limiting. It does go away on its own. This is a nice, busy sheet here. You guys can see it really well, but it's a good algorithm of how to treat this. At the top, one of the first questions is, has the patient been in the hospital for the last 3 days? No. Does the patient have bloody diarrhea? If it's yes, then, does the patient, are they febrile? Diarrhea, you follow the left-sided diagram here. Some of the things that you want to worry about, of course, if there is blood, is checking for the bacterials, the E. coli, stool lymphocytes, lactoferrin. If they're not having bloody diarrhea, you want to follow the pathway to your right. Let's put here. Having, then if they're not having bloody, or they're febrile, or they're having more than 6 stools, if the answer is no, then you're not going to really do much more than we're talking about. If the answer is yes, then you may want to check some of the blood test and stool cultures and start them on an impaired antibiotic. If your answer is no to this algorithm, there's really no reason to do stool testing. Prevention, very important. Hand hygiene. Hand sanitizer has been very helpful in locker rooms. Pre-pandemic, there was a time that in the Browns locker room, you couldn't go 5 yards without there being a full dispenser of hand sanitizer. That's changed a little bit since the pandemic through a couple of remodels. You want to avoid sick contacts with no infection. Definitely promptly removing the player who has any symptoms.
Avoid water bottle sharing.
Yeah.
It's not so much at the professional level where,
Yeah.
there's one person dispensing the water directly into their mouth most of the time, but like at the younger levels, it's a huge issue. My kid has to take a water bottle to school every day, and there's like a whole discussion at the house last week about how Jenny doesn't like drinking out of Emmy's water bottle. And I was like, why is there a kid drinking out of your water bottle? Well, we like to see what everybody else brought to school today, water. So they're like all sharing water bottles, and we just had a huge outbreak of COVID in the classroom, and everybody's like, I wonder why everybody got sick.
Yeah. That's something I don't think about that often.
Yeah, at the professional level for sure, but the younger kids are
and even
terrible.
Even I've seen this in the last 10 plus years, is even at the high school level. Most high schools that have the resources, if kids don't bring their own water bottle, they have separate water bottles for people to use. But no, that's a very valid
Yeah,
point.
and after COVID, I think people got a lot better about bringing their own water bottles, because it became one of the standard recommendations. And before COVID, it was community water service.
From my 16-year-old son takes a hard water bottle to school every day. And to me, that's so foreign. That was nothing that Susan and I had to deal with growing up. And, I don't remember ever going to the water closet at school anyway, maybe once a week, but we were probably very underhydrated. But
Yeah, there's no water fountains anywhere in school. We never carried water bottles.
Yeah. And I know during COVID, they turned off a lot of the water faucets. A lot of it transition to the bottle filling taps, which I think are very beneficial. But the prevention, you want to get players out of the environment. You want to have people avoid being around sick people, good hand hygiene. Norovirus, we can't eradicate it. The cruise ships can't eradicate it. But this is something that you can prepare your environment very well. You don't want to use alcohol-based cleaners. You do want to use something with chlorine or hydrogen peroxide. Here's some of the examples here. Clorox Healthcare has hydrogen peroxide with Purell Surface. Santa Claus, you guys have seen these numerous times. The Santa Claus has different colored caps depending on what's in it. I use the gray cap on ultrasound, right? It doesn't have to bleach out. We don't want to bleach up on ultrasound scan and chew up the rubber. Purell Surface, that was one that really boomed during COVID. I wish I had stock in it. Best practices, again, remove any symptomatic player from practice. Push PO replacement fluids. If they can't do that very well, you want to do some type of IV fluid. But with the oil replacement, you want something with a lot of salt in it. Watery diarrhea, no antibiotics, no labs. Bloody diarrhea, start empiric azithromycin, get labs. Sparingly use your loperamide, your pepto-bismol, and clean the environment, something that actually is going to kill potential bacteria and virus with bleach and hydrogen peroxide. Resources. That's it. Quick, dirty. I know not a whole lot of significant content, probably nothing new for you guys, just coming straight out of residency. Hopefully this is back of your hand type information that you've been practicing for a while. Any questions?
Austin and I, as conjoined twins with our reflux, what's your reflux protocol for treatment when people come in and just have like consistent reflux as opposed to just take something that
I had
bothers them?
So I am a big believer with kind of acute symptoms, calcium carbonate, Tums type thing, along with the Pepcid. I think the Pepcid AC over the counter is like one of the best tools that has ever been made.
And you just put people on chronically?
So I will acutely, right? And then PPIs take about 3 days to really kick in.
Yeah.
They do not work right away, right? We all know that. We know the mechanism of how it works. When I have people who have chronic GI issues, I tend to explain to them, okay, this is how calcium carbonate works, right? You have acid in your stomach, neutralizes it right away, so it's going to work the quickest. Pepcid blocks your histamine reaction to all that acid, and that's going to be the second quickest, and that's within hopefully 15 to 30 minutes. You're going to get relief. And then PPI, I tell them PPI is medicine that actually has to go into the factory, turn the factory off of making your acid. That can take 2 to 3 days. It took me about 3 years to convince Joe to get Prilosec out of the game day training.
People were just taking it one day
And wanting it for acute treatment. And I'm like,
Doesn't make sense.
yeah. This is what happens when you've just been working with a non-sports ER doc for 4 years prior to me getting here. But I'll do Pepcid. I'll have what was the one that got pulled off the market? Tagamet. One got pulled off the market a couple of years ago. Zantac, yeah. Cimetidine.
Not that one. It's one of those.
Yeah. But that was the one that had potentially had carcinogenic chemical mixed in it from the plant. But Pepcid is the one that's still on the market. But yeah, so I give people Pepcid. I give them a couple of or 2 or 3 Tums, depending if you have extra strength, for acute symptoms. And if that persists for several days, and that medicine is working, or if it's not working, then I'll transition to PPI. I've been taking omeprazole every day for the last 18 years probably. I am not worried about my bone loss. I'm not worried about brain loss. I think the studies that came out about 3 or 4 years ago, elderly patients and potential early dementia from PBIs are very skewed and very to results.
Yeah, I'm on Mexican every day.
And I have found, because I don't, because it's been over the
We
counter.
reach for our coffee.
Cheers. Every time, so like, I can't do jalapenos because jalapenos are a trigger for me, like. Triggers, there's a shot at the Fairmont, the La Verdita, right? That's why I don't drink it, because I can't sleep at night. It's got anything with jalapeno, it will disrupt my stomach and too much of it, I can't sleep, and sometimes I can't even stop it with all through medicine, even. I'll get breakthrough if I might, because I take my PPI every morning. Rarely do I ever forget. Spicy sausage, like Italian sausage, is another one of my killers.
Yeah, you start to figure it out over.
Yeah, so if I,
Yeah, I know, I'm marinara big time,
yeah.
garlic and marinara in general.
I would die.
I know,
Yeah,
well, I
it's
still
for
fight through
pizza.
sometimes.
Yeah, not for pizza, I fight through, but like I've come up, I'll much more likely go pesto than red sauce any day of the week,
Same.
yeah.
Yeah, and knowing your triggers is good, but yeah, and my 16-year-old has the exact same symptoms that I do. I'm trying to avoid him starting a PPI for a while until he's done growing, there are some concerns, but I'm not concerned about me, I am concerned about him. And I just have him take Pepsid, and he gets breakthrough time. He nightly goes, it has a couple of times every night, gets him home to the second dose of Pepsid when he gets home. Sports practice. Yeah, but PPIs are good. The one thing that I have found that with generics, Carrie, I don't shop. Carrie will go to Target or she'll go to Costco and bring me kind of three pack, I'll get 42 days worth or whatever. If I go from one generic to another, I'll have a couple of days breakthrough. And if I've trained Nexium, the generic, desomeprazole.
It's
Esomeprazole.
so livable.
I haven't found a difference between omeprazole and esomeprazole, but pentazoprol. Proton. What's the other one? Begins in there. Lansoprazole.
Yeah.
Yeah. So that one.
Yeah.
Does not work for me.
Yeah.
Carrie brought that home last time, and after 3 days, I'm like, well, why is this working? And it was bad. I was like, dude, I never buy this. So, but I remember when Protonics was still branded when I was a resident.
Yeah.
And it came out, and I used a lot of it, and I still have some Protonics. Memorabilia. Have a blanket that we take to track meets.
That's great.
Protonic, that's awesome. Yeah. I've had that for 23 years.
Days of impressive. Being able to do that stuff.
Yeah, right.
Yeah.
Third year was when the sunshine laws took effect. Still could get, and there was also that our work was supposed to take effect, but we never changed our hours. Part of that transition didn't happen, and I still got drug reps to do stuff for us, pay for our Christmas parties. What else? What other questions?
One comment I just had is I know a lot of people, just come back from India, there's a lot of medical tourism for GI stuff with Ayurvedic medicine and homeopathic medicine. Not obviously, research isn't as strong, but just anecdotally, a lot of people have had either complete relief or even like just dialed down the intensity of their symptoms for like GERD and a lot of